That's something that now when I meet with patients, I try and remind them like, yes, we do have these side effects that can happen and make sure that they're informed, but also try and reassure them that not everyone gets it as severe as maybe the movies and TV shows portray.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS, and today we're talking with Dane Fritzsche, informatics pharmacist from the Fred Hutchinson Cancer Center at the University of Washington Medicine in Seattle, about what oncology nurses need to know about alkylating agents for patients with cancer. This episode is the first in a series about drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Dane.
Thanks. Happy to be here.
So to start things off today, can you give us a brief overview of the drug class alkylating agents and kind of a brief history of their place in oncology care?
Alkylating agents are a very interesting class of chemotherapy agents, both mechanistically as well as historically. I was doing a bit of a review to remind myself kind of where that story kind of begins. Because I remember back in pharmacy school learning this was actually the first class of medicines used to treat cancer. And it actually starts way back in World War I with the use of sulfur mustard gas in kind of a military fashion, and then noticing some of the responses that soldiers as well as civilians who were accidentally exposed to that, they would develop things like bone marrow suppression as well as other antitumor effects. Sadly, it's rough to see mustard gas as being the first agent to lead to something so remarkable because it was, a weapon of devastation. But it did lead to some breakthroughs. And then notable pharmacologists like Lewis Goodman and Alfred Gilman, I'm not sure if your listeners would be aware of them, but they're kind of famous in my world from pharmacy. They write what we call the Blue Bible, which was the Goodman and Gilman pharmacology textbook that basically all of us have read. And they began doing studies in the early 1940s looking at using these alkylating agents to treat malignancy.
I am a nerd for history, and so I am always fascinated when I do dive a little deeper in understanding where we came from and how we got here. I'm sure many of our listeners, and maybe you as well, have read the book, The Emperor of All Maladies. It does kind of do a walkthrough of that history. It is just fascinating to understand that it was sort of like, well, let's try this and see how it goes. And just understanding not only how far we have come from that, from the start of oncology care, from a systemic treatment perspective, but also still like how close we are to that. It's just, I think both of those things I find just very compelling and very interesting and just give me a great appreciation for all the great tools and supportive care that we have in play now that were not even thought of or invented back when in trialing some of these very early agents like the mustard gas and these alkylating agents. So if any of our listeners have not read that book or just understood the history of how we got here, super interesting. And I think you'll enjoy reading through that.
Yeah, I agree with that, that recommendation to read The Emperor of All Maladies. That was one of the first books when I was a second-year resident here at UW Medicine. I'm not sure if the listeners are aware of pharmacy residencies and how that whole thing works, but you do kind of a first-year general residency and then move into your specialty residency your second year. So I did one in oncology, and that was one of the first recommendations was to dive into that book if you had not. So I highly recommend taking a dive into that because it does give you a very interesting kind of historical perspective on how far we've come.
And I love how you're walking through this chapter and you're not quite sure where they're headed or what it's talking about. And suddenly you realize what drug it is. You're like, oh my gosh, I give that drug. That's so amazing. That's how it got here. So anyways, this is just me nerding out a little bit.
Yeah, I'm nerding out right there along with you. Totally.
Let's dive a little deeper just into the actual mechanism of action of how alkylating agents work when we are applying them in sort of the anti-neoplastic setting.
Happy to dive into that. Their mechanism of action can vary a little bit from agent to agent, but I'll kind of stay at a high level, more broad speaking. But it involves a covalent attachment of an alkyl group. That's where we get that alkylating name from for alkylating agents to DNA. This leads to cross-linking either intra-strand or inter-strand, depending on the agent. And this disrupts various cellular processes such as transcription, which is DNA replication, and translation, the conversion of DNA to RNA, and ultimately, in some cases, making proteins down the line. This ultimately leads to like cell cycle arrest and eventual apoptosis or cell death. These agents, interestingly, are considered to be cell cycle non-specific, whereas some other chemotherapy agents that I'm sure the listeners will learn about in the future episodes, well, they'll requires a cell to be in the cell cycle, meaning growing or dividing. And these agents will actually work even if the cancer cell at that point in time is not actively undergoing replication.
Thank you for calling that out. I think that's a really interesting and important component of understanding how some of these kind of historical, classical chemotherapy agents work, of the cell cycle specific versus non-specific, and how that translates to the timing of when we give drugs and how and why we give them in certain doses and cycles, the days on of treatment, the days or weeks off of treatment. It all kind of comes back down to that part of that rationale is in the way that the drug actually functions as part of the cell cycle. So I think that's an important point and distinction to make as we talk about not only alkylating agents, but other classes that we will eventually address, of just understanding, how does this drug work? In which category does it fit in?
It also gives you a bit of appreciation too for all the work that's been done looking at like tumor kinetics and how, a tumor is dividing, how quickly that's happening, and then taking in knowledge of, like you said, when these agents work, and then trying to divide the best way that we can attack a malignancy.
In terms of alkylating agents, there are some subclasses that sort of fall underneath that. Can you give us some examples of those subclasses and specific agents that come from those subclasses?
So one of the first subclasses, meaning in their development, is the nitrogen mustards. The kind of the early example of this is mechlorethamine. Some of the other more recent and probably familiar agents in this subclass include cyclophosphamide, ifosfamide, melphalan, chlorambucil. Some other subclasses include the platinum agents, which are also very commonly used, such as cisplatin, which was the first one in this subclass, carboplatin, and oxaliplatin. There's also alkyl sulfonates, with busulfan probably being the most commonly used one clinically. There's the subclass nitrosoureas, with examples like carmustine and lomustine. They each have kind of their other acronym names that are commonly used. So carmustine is BCNU, or lomustine you might hear commonly referred to as CCNU. And then the last subclass that I'll talk about is the triazines and hydrazines. And these kind of two agents that you'll see commonly used more in your hematologic malignancies is like procarbazine or dacarbazine. There are some other subclasses, but those are kind of your big ones, with also the most commonly used agents.
I also, just again, that perspective of like when you classified them as the more recent ones, they're still like 20 or 30 years old at this point.
Totally. Yeah.
Which I don't know if that's more of a reflection on my age or the drugs that are aging. But again, it does give perspective that we've had many of these alkylating agents for a very long time. And yet in some disease states, they are still considered a core part of frontline or, early stage treatment. Even though we know we've made so many other advances when it comes to targeted therapies, immunotherapies, these are still part of the mix. And so I think it is important for us to not, even though they're older drugs, and obviously they are fraught with some additional side effects and things that we're able to avoid with some of these more recent classes, I think it's still important to understand that these are still very present in many treatments. And it's just important for nurses to stay familiar with them, even though they are older.
Totally agree. When I was a second year oncology resident at UW, when I was learning about these, I was like, wow, I can't believe, some of these agents are older than I am. And still I see them every day and they're staples in therapy. Despite their toxicities, they still have a very strong presence in oncology care.
The dream might be that someday we don't have to use these anymore because we do get so personalized and understanding sort of those genomic underpinnings and can eliminate the need for these types of broad drugs. But I think that we're not there yet. So we got to still keep this in the conversation. So let's talk about those side effects that we've maybe wish we could avoid, but they still come with these types of drugs. What are some key considerations that you think nurses who are managing patients receiving these various types of alkylating agents, what are some key considerations for us to keep in mind?
Kind of the first thing that jumps to my mind when thinking about alkylating agents is their toxicities, and then their supportive care agents that we use to make sure that we're treating our patients well. and making their care optimum. So when I, as an oncology pharmacist, would look at these orders, I immediately am jumping to, are we giving them appropriate antiemetics? Because a lot of these agents are highly ematogenic or moderately ematogenic by NCCN. A lot of them have other organ toxicities, like are really harsh on the kidneys. So are they getting their pre and post hydration? And then also many of these agents are very bone marrow suppressing, meaning they're targeting the red blood cells, they're hitting platelets, they're reducing our ANCs and making patients at higher risk for infection. So do we need growth factor support here? Are the patients, their current labs, are they able to take another dose at this time, or do we need to dose reduce or delay therapy because their platelets are just too low now? So a lot of it really is looking back at these regimens, recognizing that there's a lot of other agents that we're giving along with these to make sure we do it safely.
Those are great recommendations. And we spend a lot of time, I think now, trying to make sure that the narrative of what it means to be getting anti-cancer treatment. And we even try to avoid just saying chemotherapy, although that broad term, people know what that means when you say it. But we know, obviously, in our world, in our space, that chemotherapy, which is what alkylating agents are, is not the same as immunotherapy or targeted therapy. And so when we're teaching patients, we do try to use the right term and explain that, oh, well, your therapy includes an immunotherapy or a targeted therapy, maybe. And so what you think of, air quotes, chemotherapy, you're not going to have those side effects. But this is what we're talking about when we say chemotherapy, are these types of drugs. And unfortunately, all the horrible things that movies and TV show for somebody who they're trying to portray receiving chemotherapy in the classic definition sense, those are all the realistic side effects. Thankfully, as you mentioned, lots of great supportive care agents that we can give to mitigate lots of them, the nausea, the vomiting, hydration, things that really we can prevent those severe toxicities with the right proactive approach to making sure that they have those agents as part of the treatment plan, having those rescue medications at home. So it doesn't have to feel as horrible as it once did, but the reality is that it's important still to emphasize, if your patients are getting these truly chemotherapeutic drugs in this alkylating agent class, that all of the unfortunate nasty side effects that we are happy we can avoid at times are a reality when these drugs are part of the regimen.
I remember early on in my second year residency when I was meeting with some patients in the hospital who were starting these kind of therapies. And this particular patient that comes to mind, he was very apprehensive with starting therapy, and he was going to be receiving, as a part of the regimen, an alkylating agent. And he had read all those horrible side effects, and he had had grandparents who had had cancer back in, I think he was saying, like the 70s and 80s, and remembered how miserable his grandparent at the time was. And he didn't want to go through that. So I spent a lot of my time kind of reassuring him that, yes, these side effects that you read about and hear about can happen, but we've come a really long way with preventing them and making sure that we're doing this safely, and that you're not going to be just miserable and something you kind of have to bear. So that's something that now when I meet with patients, I try and remind them, like, yes, we do have these side effects that can happen, and make sure that they're informed, but also try and reassure them that not everyone gets it as severe as maybe the movies and TV shows portray.
And I think you bring up an excellent point that it's always important to ask patients, if they are starting treatment for the first time, or even if it's a subsequent line of treatment, kind of asking what their frame of reference is. Do they have friends or family that have gone through treatment for cancer? And what was that experience like? Or what do you know about their experience? And just being able to accurately give them the right frame of mind and perspective of how their experience might be different from what their family or friend experienced, whether that's because it was 40 years ago, or it's just an entirely different disease process and treatment plan. It is always important just to make sure that whatever a patient's preconceived notions that they have about what they're going into, that we can do what we can to perhaps correct those if they are not entirely accurate, because that can remove a huge burden of stress and worry if we can hopefully say, well, don't worry, your drugs don't cause those side effects, or we have these great agents that can control them better. So I think that's a great tip to remind us of just checking in with patients about, what do you think is going to happen, or how are you expecting this to go? And let's see if that is what we expect.
Exactly.
I know we talked about several subclasses of the alkylating agents, and those are all very individually unique. But can we talk maybe just a little bit about what are some ways that oncology nurses and pharmacists can collaborate to provide optimal care and symptom management, side effect management for patients who are receiving alkylating agents?
Honestly, it's probably one of the most important things is collaborating together to help provide optimal patient care. And to me, kind of the biggest thing that jumps out is just good communication between the various team members. I can't tell you how many times I would learn crucial information either from an infusion nurse chatting with the patient or walking down the hall or giving a call to one of our lovely clinical nurse coordinators here at Fred Hutch. I always wanted to make sure that I go in and have the full picture of where the patient's at, what, if any, challenges there's have been with this patient's particular case, just to make sure that I'm up to date about them and able to provide as good of care as I can. So I think one of the best things for our teams and our nurses and pharmacists to work together is always good communication. And I think what comes along with that good communication is you start to develop a rapport within your team. And with that rapport, when something's not looking right or maybe you're not totally understanding, I think it opens up a pretty easy avenue to just ask questions. Because at the end of the day, some of us might not feel empowered to ask questions when we're not totally sure what's going on. But once you have built that rapport, have had good communications within your team, you ask those questions, and who knows, maybe you're catching something that no one else caught, and it's a big safety issue or something that was just totally missed.
I envision I'll be saying this on every episode in this series, but with the number of drugs that we have now to treat cancer and kind of what a wonderful place to be with so many options, it's more important than ever for nurses and pharmacists to collaborate and to learn from each other and share information. It's seemingly impossible for any of us to know all of it. We can't know everything, especially if you are in a community-based setting or where you're treating multiple types of cancer versus a subspecialized setting, maybe in an academic center. It's important that we rely on each other to share information. So if new drugs are approved or there's new indications, new side effects that have shown up in post-market data, just sharing that with your team and with your colleagues so that everybody has our best shot of staying up to date on information that is coming out at a speed that it's hard for any of us to consume. So I love what you've shared about just building that rapport with your colleagues on your team, an interdisciplinary team at that, and understanding that we all bring certain skill sets and knowledge levels and expertise that ultimately all contribute to a great patient outcome when we're working together and trying to work in tandem to provide that optimal care.
Exactly. At the end of the day, we're all there to make sure we get the best outcome that we can.
For sure. Talking about some of those symptoms and side effects to manage, can we just go back and talk a little bit more about some of those common adverse events that we see from the alkylating agent class? How can we provide the best education to patients about those typical adverse events so that they are prepared and they feel equipped with the knowledge they need to communicate well with their care team?
Unfortunately, like we kind of mentioned briefly before, this class of drugs does come with kind of those generic chemotherapy side effects that we think of: hair loss, nausea and vomiting, and bone marrow suppression. And that just comes as a function of how these work. These agents are not selective for just cancer. They're more selective for rapidly dividing cells. So that leaves our normal cells that rapidly divide, like our hair, our GI tract, our bone marrow, to get hit by these. So each agent themselves can have varying levels of how much nausea and vomiting they cause or what type of bone marrow suppression. Some agents will see a lot more platelet suppression and not as much on the neutrophils. So there is varying levels of that. And that's where understanding regimens and diving into the data helps a lot. And then there's also agent-specific side effects that you don't really think of as the function of, oh, this is an alkylating side effect, but more of like, oh, it's a classic cisplatin side effect, for example, kind of notorious for being renally toxic and requiring that pre and post hydration to help prevent, and something that we're always checking their serum creatinine before they get their doses to make sure their kidneys are still happy and okay. And actually that side effect of cisplatin is what led to the development of carboplatin. And carboplatin, thankfully, is not as nephrotoxic. We really don't see a lot of issues with renal dysfunction, but we see a lot more hematologic toxicity with that agent, specifically the platelets, in fact. Some other side effects that we can see with these agents kind of can run together. So like ifosfamide and cyclophosphamide, both of those agents can cause something called hemorrhagic cystitis. For cyclophosphamide, this is really seen at your higher doses. So I kind of think of it as more of your transplant level doses. But I actually have had a couple of patients in the breast oncology clinic, which is where I primarily worked prior to my new role as an informatics pharmacist at Fred Hutch. We did see it a few times in breast cancer treatment, but a lot less common. But kind of those side effects there, that's, really important. I remember chatting with my breast cancer patients about the importance of not holding their urine very long, making sure they're staying well hydrated throughout the day, and making sure that they urinate before going to bed so that they don't have that much urine, which holds the byproduct during the metabolism of biphosphonate and cyclophosphamide acrolein in the bladder and irritating the bladder and potentially leading to that side effect, which it can be very uncomfortable. One other side effect I did want to mention briefly was just more of a special side effect seen with busulfan. That's an agent that we use in our stem cell transplant conditioning regimens, and it's neurotoxicity. And that's kind of why for our nurses that work with our transplant patients, you'll see them use anti-seizure medications beforehand to help prevent this. I know at our institution, we'll commonly see agents like levetiracetam, depending on the patient's specific case, to help prevent that.
You've brought up a great point that for this class of agents, you can't just assume that all drugs have the same side effect just because they are in the same class. And that's probably true across all classes. I mean, every drug has a little bit of a nuance to it. We would never want to be complacent in just assuming that every drug, if it's in this class, has all these issues to worry about. And I think that information and that education obviously has to trickle down to the patients. And so when you think of not only just the verbal instruction and education and coaching that we provide to patients, but most sites provide some sort of written information as well. And it's really important just to make sure that even if the information itself can't be completely customized, maybe you have like a booklet or a binder or something of information that you sort of routinely give to all patients, and you try to cover the most common, the frequently experienced side effects. It is important as you sit through with your patient and help them to kind of customize that information to meet the needs of what their treatment provides. And so, as you mentioned, maybe they don't need to be overly worried about their platelet count, but they do need to be aware of their risk for infection because their white blood cell count might be more likely to take that hit. And so, again, understanding that the educational materials that we provide to patients might have to be a little bit more generic and understood why that needs to be. But taking that time to sit through with patients and help them to really make marks in the margin, circle things that are really important or cross through things that really aren't going to be relevant for them in their treatment. That can help give them a more accurate reference when they go home, because I think it's very easy to worry about everything. Terrell says I'm going to have all these problems, then this is going to be a rocky road to go down. But if we can provide a little bit more customized and specific instruction about these are your specific drugs or your regimen, likely you're getting more than one drug. So here's the things that really we are going to be watching, or things that you at home can be focused on, or as you mentioned, if it's ifosfamide, and those very specific tips about not just, you might have, hemorrhagic cystitis, but here's what you can do to help hopefully avoid that. Drink lots of fluids, don't hold your urine, urinate frequently on a schedule, things like that. Really trying to provide actionable education to patients. And so it's not just what to worry about, but what to do, whether it's things you can do to avoid or to limit or lessen side effects. Like, it's very important to take your anti-nausea medications on a schedule for these days because we want to prevent it from even happening, not wait till you have it and then try to correct that issue once you're already suffering with nausea and vomiting. So, a lot of attention to detail in that education process, reinforcing that education at every subsequent visit. It can't be overstated how important that is for all patients in all classes of drugs, but given the severity of these side effects, especially when patients are receiving alkylating agents.
Yeah, certainly. You bring up a great point, and something that when I am training now oncology pharmacy residents that I always bring up. Hey, I'm bringing in these documents and I'm highlighting areas. I'm crossing things out. I'm underlining. Because one thing, can you imagine just trying, like, you put yourself in that patient's seat, how much information is being thrown at you? How are they going to remember, I remember the pharmacist said this part's important, that part's important. And then the next thing I always drill my residents on when I'm teaching them how to provide actionable and helpful information about their regimens that they're getting is kind of like you're saying, outlining those expectations. How do you prevent these side effects? When do these side effects even start to show up? Like, am I going to immediately be nauseous right when the cisplatin gets turned on? Well, maybe. Not super common, but it's more common that we'll see it in, at the end in the next couple of days and within the next 72 hours, or going into the nuances between acute versus chronic nausea and things like that. So it's really trying to give, like you said, empower the patients with information. How do they prevent this? What are we doing to help prevent it? And then when should they call us? When is the stuff that we're preventing didn't help? When should they call us to get more help?
And obviously, my answer for that was always anytime you have a question or anytime you're concerned, that's when you should call. But you're right. There are some specific indicators that are really important just to give them that clear understanding, because There are some, depending on how anxious a person is just generally, especially with starting a new treatment, you want to give them some clear understanding of what is normal but uncomfortable and what is not normal and uncomfortable. I remember having patients who were developing infection and sepsis, and they were under the impression of, oh, well, I just thought I was supposed to feel bad. Well, no, that's not at all our goal. And while there's gradations of that we maybe can't prevent every side effect, fatigue, things like that, some of that is definitely going to be part of the package. We do have to be very clear of this is a threshold. If this is how you're feeling. If you literally can't get out of bed, that you feel so bad, that is not normal. So giving them some of those clear indicators of really when you should contact us. But again, always hoping they understand that any concern or question they have, we want them to ask so that we can reinforce what they're experiencing and provide that guidance for them.
Yeah, I think you bring up a very interesting patient scenario that I, as a pharmacist, always worried about. You brought up the more anxious, perhaps, is going to call us maybe when they don't need to, but I would always prefer that out of patients, like kind of like you mentioned, any kind of question, please call us. It's those stoic patients that, I'm nauseous and I'm vomiting 4 times, but I'm supposed to feel bad on chemotherapy and they don't call us. And then they come to a follow-up appointment with me and they're like, oh, I only throw up maybe 4 or 5 times a day. And I'm like, whoa, what's going on? And then we back up and, how haven't you called anybody? And, we're starting from square one there. Like, how are we going to treat this nausea and vomiting that's pretty severe at this point?
And some patients are not only stoic, but very resourceful. They're like, well, I don't feel great. And I normally take Tylenol when I don't feel great. So I'm just going to take some Tylenol. And again, like we all know all of the problems with that approach. So that is just a very different approach to educating patients of understanding in a different context. That would be a very appropriate approach to dealing with how you're feeling. But here's the reasons why we have to caution against that. And this is really not even just about alkylating agents, but just a general approach to educating patients about whatever their treatment is, of kind of understanding just who that patient is, how they approach caring for themselves, or who else is their caregiver, bringing them into that conversation and just providing some of that support that, again, is not a one-time event. It's part of the process the entire way through a treatment. And so we can never ask if they have questions, reinforce the education that's already been provided. We really can't do that enough. But I think you've provided some great information for us to consider, especially specific to the alkylating agents today.
Happy to continue sharing those things.
So, Dane, what does the future look like for alkylating agents in cancer care?
I think we kind of touched on it a little bit previously, like you were saying. I hope that we are able to at least reduce exposure to these agents, maybe use them less often, or in some cases, still be able to give an alkylating agent, but maybe have it attached to an antibody, like in these antibody drug conjugates. I do know there's a few of those that have been used and are in study. That'd be a great way to kind of get the alkylating agent, which still is really strong at fighting cancer, but make it perhaps a little bit more targeted. Another point that you had mentioned also previously is maybe finding those patients whose tumors are particularly sensitive to these alkylating agents. So we're using them in the population that's going to benefit most from them, where maybe we're willing to handle those side effects and risks that come along with it, at least willing to accept that risk a little more.
I think your comment about the antibody drug conjugates, I hope that's another episode, because I think those are just as fascinating and interesting of how we kind of got to there as well. But I agree. I'm not sure that we will ever be completely done with them. But as you mentioned, maybe we can find an approach that limits or eliminates the severe toxicity, but still preserves the benefit for the patients that are the most appropriate to receive those drugs. So hopefully we'll see advances to continue in that direction. Well, Dane, thank you so much for all the information you've shared today. I think this is a really great series for our nurses to be able to kind of peel back the layers of anti-neoplastic treatment and understand how each class is different. And so I really appreciate your time today with our first alkylating agents episode. Before we close today, I do like to ask just a few quick wrap-up questions to help summarize our conversation. What are some common misconceptions about alkylating agents?
Probably the biggest misconception that I've found is kind of what you mentioned earlier, that all of these drugs come with intolerable side effects, that you're going to be miserable. And I think that's a misconception that we as healthcare professionals can really help alleviate with our patients, reminding them that, yes, they do carry risks, but we also have a lot of supportive care agents to kind of help minimize that toxicity. And then you have this whole team of professionals behind you to help carry you through the treatment.
What's something about this topic that's not often discussed, but you wish more people knew about?
For me, I think It was the history of the topic, actually, that these agents, which now can lead to cures in some cases, depending on the disease state, really kind of started from a kind of a dark starting point. I had heard that in the past and then totally forgot about it until I was kind of preparing for this episode. And it's like, wow, it just gives you this, I don't know, I'd call it serendipitous, right? Something that's so awful happening in World War I led to saving lives later.
What additional training or education do oncology nurses need to help further understand alkylating agents?
I don't know that oncology nurses need more specific training for alkylating agents. I think it's something just to remember that these agents all come with kind of your standard chemotherapy side effects. And then each agent itself kind of has its own side effects that maybe they need to brush up on. So I always just remind my nurses, feel free to reach out to your pharmacist if you have questions about a regimen that they're on, or, feel free to do a little reading on any of your favorite websites to gather information, just to remind yourself, oh yeah, cisplatin's the one that causes a lot of kidney toxicity, or carboplatin's the one that really hits the blood counts. Something just so if a patient has questions while they're in the chair or, calling you for triage, you're kind of most equipped to answer those questions.
And I would agree with that. And just in addition, now we are oftentimes now maybe giving these old, very old drugs that we feel very comfortable with, but we're giving them in combination with something that's newer or brand new. Just understanding, revisiting these drugs that, the side effects of this drug like the back of your hand, but have we given it before in this context or for this disease or with this additional drug on board? And so, again, just never be afraid to just revisit that package insert, understand what's there, what information is there, so that each patient you're approaching with a fresh mindset of what this drug does, how it works, and what we need to be aware of. So those are great tips. Finally, what are some additional resources for nurses or for patients even that want to learn more?
Personally, I gravitate towards the HOPA, which is the Hematology Oncology Pharmacy Association. They have a combination with ONS, and there's these lovely patient handouts. And I would actually use those at Fred Hutch when I was teaching patients about the regimen. They have both oral chemotherapy information guides as well as IV and regimen-specific chemotherapy information guides that I would pull out, and they try their best to, when they have whole committees of oncology nurses, oncology pharmacists, kind of putting in what information is the most important for patients to take away from this. And then I would always kind of go in and highlight in those. But that is certainly one of my favorite resources that I would use. Some other tips for some other areas that I often will direct patients is third-party sites like ChemoCare. If they ever have questions about specific agents, I think it does a really good job at breaking down more of your general basic information that they might need to know. And then another one that I always go to is cancer.gov. Has a lot of great both healthcare professional information as well as patient level information.
That's great. I think that those are all great resources that you mentioned. And I think many institutions, larger organizations or health systems may have more restrictions on what they allow to be used as formal patient education. And so I think whatever the policy is at your organization, it's important just to make sure that you are thoroughly reviewing the sources that they recommend, whether there's something that maybe is embedded as part of sort of another vendor that your hospital uses for education information, or it's something that's connected to your electronic health record. Just make sure you read through it and that you think it's representing the information in an accurate way. And if it's not, make sure that you escalate those concerns to your leadership so that you can advocate for the best source with the best information, the most accurate in a patient-friendly way. Just don't be afraid to read the fine print and make sure that it's saying what you want it to say. But I think you've given some great examples as resources as well. Well, thank you again, Dane. It's been a great episode. I love talking about just kind of, like I said, the nerdy stuff, getting down to the basics. I think this is very helpful. Do you have any final comments you'd like to share with our listeners today?
Harkening back to good team communication. At the end of the day, we're all out there to help take the best care of our patients. So work together, work hard, ask questions.
Wonderful. Well, thank you so much.
Thank you. I really enjoyed being here.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.